High-yield neuro, migraines and headaches. Welcome back to Medical Rocket. Let's talk primary headaches and focus in on the big one, migraine. First up, what's a migraine really like? It's unilateral, meaning one-sided. Pulsatile, that classic pounding feeling. Moderate to severe in intensity, and it can last anywhere from 4 to 72 hours. Now here's the kicker. Physical activity makes it worse, so your patient doesn't want to move. They just want a dark room, silence, and zero motion. Key associations? Photophobia, phonophobia, nausea, vomiting, and in some cases, an aura. What's an aura? It's a set of reversible neurological symptoms. Think flashing lights, zigzag lines, or odd sensory changes like tingling. They build up slowly over 5 to 60 minutes, and they usually show up before the headache starts. So, how do we diagnose it? Let's go ICHD-3 criteria. You need at least 5 attacks, each one lasting 4 to 72 hours, and at least 2 of the following: unilateral pain, pulsating quality, moderate to severe intensity, or worsened by routine activity, plus at least 1 of the following: nausea or vomiting, or light and sound sensitivity. Treatment? For acute attacks, first line is triptans like sumatriptan, paired with an NSAID. Other options? Ergotamine or antiemetics like metoclopramide. But what if migraines happen often? Like 4 or more times a month, or they're really disabling? Now you're thinking prophylaxis. Your go-to options: beta blockers, especially propranolol, tricyclics like amitriptyline, anticonvulsants including topiramate or valproate, and the newer players, CGRP inhibitors like arenumab. Smart tip: always tailor prophylaxis to the patient's comorbidities. For example, pick propranolol if they've got hypertension too. That's the core on migraines. Headache types. High-yield clinical breakdown. Let's finish the primary headaches and hit those critical red flags. Tension headache. The most common and often the most ignored. Pain is bilateral, band-like, tight, pressing, not throbbing, not worsened by activity. And there's no photophobia, no aura, usually triggered by stress, poor sleep, or neck tension. Treatment? First line, NSAIDs. For chronic cases, go with TCAs like amitriptyline. And throw in some relaxation techniques. Cluster headache, the beast. This is severe, unilateral periorbital pain, like a dagger behind the eye. Each attack lasts 15 to 180 minutes, but it can strike up to 8 times a day. Associated features: lacrimation, rhinorrhea, ptosis, meiosis, that's Horner syndrome. And here's the pattern: clusters. They come in waves, often for weeks, especially at night. Acute treatment: 100% oxygen plus subcutaneous sumatriptan. Prophylaxis: start with verapamil. Other options: lithium or steroids if needed. Secondary headaches, red flags. If you miss these, the consequences can be fatal. Use the SNOOP mnemonic to screen. S, systemic signs: fever, weight loss, HIV, or known cancer. N, neurological signs: new focal deficits, altered mental status, seizures. O, onset is sudden, thunderclap headache. Think subarachnoid hemorrhage. O-never, older age. Over 50? Suspect temporal arteritis. P, positional changes, papilledema, or pregnancy, especially for cerebral venous thrombosis. Investigations to remember: CT or MRI brain, first step. If you suspect SAH and CT is normal, do a lumbar puncture. For temporal arteritis, get ESR. For venous sinus thrombosis, order MRV. Always think: pattern, red flags, appropriate imaging. Smart medicine saves lives. And that's how you dominate headache questions, with calm, confidence, and clinical precision. Only here on Medical Rocket. Let's test your clinical instincts, rapid fire style. Question 1. A 28-year-old woman presents with episodic throbbing headaches, one-sided, often preceded by flashing lights. What's the most likely diagnosis? A. Cluster headache. B. Migraine with aura. C. Tension headache. D. Temporal arteritis. Answer. B. Migraine with aura. The visual aura gives it away. Think flashing lights, zigzag lines, or sensory changes before the headache hits. Question 2. Which of the following is the first-line prophylactic treatment for migraine? A. Acetaminophen. B. Propranolol. C. Sumatriptan. D. Metoclopramide. Answer B. Propranolol. Remember, triptans are abortive, not preventive. Beta blockers like propranolol are the go-to for migraine prophylaxis. Question 3. A 35-year-old man has excruciating left-sided eye pain every night for the past 10 days. Exam shows lacrimation and ptosis. Best acute treatment. A. High-flow oxygen plus sumatriptan. B. Ibuprofen and codeine. C. Oral propranolol. D. Amitriptyline. Answer A. High-flow oxygen plus sumatriptan. This is classic cluster headache, and high-flow oxygen is your hero. Question 4. A 72-year-old woman presents with a new headache, jaw claudication, and visual loss. ESR is 95 millimeters per hour. What's the next best step? A. Start high-dose steroids. B. Schedule MRI of the head. C. Refer to dentist. D. Observe. Answer A. Start high-dose steroids. This is temporal arteritis, also called giant cell arteritis. Start steroids immediately to prevent irreversible blindness. Question 5. A patient presents with a sudden severe headache, described as the worst in their life. CT scan is normal. What's the next best step? A. Lumbar puncture. B. MRI spine. C. Give NSAIDs. D. Reassure and discharge. Answer A. Lumbar puncture. You're suspecting subarachnoid hemorrhage. CT can miss it, so do an LP and look for xanthochromia. Here's your cheat sheet. Migraine, acute, triptan NSAID. Prophylaxis, propranolol, amitriptyline, topiramate. Cluster headache, acute, 100% oxygen plus sumatriptan. Prophylaxis, verapamil. Tension headache, acute, NSAID. Prophylaxis, amitriptyline if chronic.